Imagine administering a drug to cure a localized skin ulcer, right? And then finding out you just permanently destroyed your patient's pancreas in the process.
Yeah, that's a terrifying scenario.
Right. I mean, you're just trying to eradicate a parasite, but the chemical weapon you choose ends up triggering this pendant diabetes.
It's the ultimate medical nightmare, honestly.
It really is. So today for this deep dive, we are dissecting a 2006 medical board exam question from Brazil that tests exactly this kind of, life or death clinical judgment.
Right, the few mark dermatology question.
Exactly. But our mission today goes way beyond just picking the right multiple choice letter. So let's lay out the exact parameters of the trap hidden in this test because it's a good one. The few mark exam question is structured as a negative selection. It reads, regarding American tegumentary leishmaniasis, all statements are correct except, and then it provides 4 pharmacological and clinical statements.
Yeah, in a board question format.
Exactly. We are going to isolate, alternate, not interfere with glycemic levels.
Which is just wild to read if you know the pharmacology.
Right. But on a superficial level, if you were rushing through an exam, that reads like a perfectly logical, safe clinical adjustment for a comorbidity.
Yeah, and that superficial logic is exactly why it's such a dangerous high-level distractor. It lulls the test taker into this false sense of pharmacological safety.
But in reality.
In clinical reality, administering pentamidine to a diabetic patient is a catastrophic error. But its cytotoxicity profile is notorious, specifically regarding the islets of Langerhans within the pancreas.
Okay, to really understand why alternative C is the exception, we need to look at the exact mechanism of that cytotoxicity because it's not just a vague side effect, right?
No, not at all.
It's a targeted demolition of the patient's endocrine infrastructure. It's like blowing up a hydroelectric dam.
Oh, that's a great way to put it.
Right, because first you get the catastrophic flood of all the stored water, which is the massive insulin drop causing severe acute hypoglycemia. But once that reservoir is emptied and the infrastructure is obliterated, there's a permanent drought.
Yes.
The beta cells are necrotic, leaving the patient with irreversible diabetes mellitus.
Wait, so giving this to a diabetic patient is basically like throwing gasoline on a fire. You're giving a pancreas-destroying drug to someone whose pancreas is already struggling.
You're throwing gasoline on a fire, exactly. That analogy maps perfectly to the biphasic nature of pentamidine-induced pancreatic toxicity.
Biphasic, meaning 2 distinct phases. Right, let's trace the biochemical pathway. So when pentamidine enters the bloodstream, it physically disrupts the mitochondria, severely uncoupling oxidative phosphorylation.
Which means it cuts off power supply.
Exactly, it crashes the cell's ATP production. And in a beta cell, the ratio ATP to ADP is the fundamental trigger for insulin release. Normally, high ATP closes these ATP-sensitive potassium channels, which depolarizes the cell, opens voltage-gated calcium channels, and causes the controlled exocytosis of insulin.
But wait, if pentamidine destroys the mitochondria and crashes the ATP levels, shouldn't insulin release just shut down entirely?
You would think so, right? But pentamidine directly damages the structural integrity of the beta cell membrane itself and the insulin-containing granules.
Oh, wow.
So as the cell undergoes necrotic death, it just ruptures. All of the pre-synthesized insulin stored in those granules is dumped into the systemic circulation all at once, completely unregulated.
It's just a massive flood.
Exactly. This triggers that first phase you mentioned, which is a profound, sudden hypoglycemic crisis. And this can happen days or even weeks into the treatment protocol. It requires intense intravenous glucose rescue to prevent a hypoglycemic coma.
Right, because their blood sugar just hits rock bottom. And then once that initial flood of insulin clears the patient's system, the clinical picture inverts completely.
Precisely. The beta cells are now necrotic tissue. They're dead.
Gone.
The pancreas has lost its capacity to synthesize new insulin. So the patient rapidly swings from hypoglycemia into severe hyperglycememia, resulting in iatrogenic diabetes mellitus.
Meaning doctor-induced diabetes?
Yes. And because it's a structural necrosis, it's not just temporary receptor desensitization. The damage is very often permanent. The patient will likely require exogenous insulin therapy for the rest of their life.
Which makes alternative C not just incorrect, but aggressively lethal if you actually applied it in a clinical setting.
Yeah, it would be malpractice.
You are giving a drug that induces catastrophic beta cell necrosis to a patient whose endocrine system is already severely compromised by pre-existing diabetes. I mean, it perfectly illustrates why the clinic is sovereign. A doctor cannot just treat the parasite, they have to treat the whole patient. If you ignore the comorbidities, the cure literally becomes worse than the disease.
And that is the essence of expanded clinical judgment. Medical boards use questions exactly like this to ensure that a newly minted dermatologist or infectious disease specialist understands the systemic collateral damage of the weapons in their arsenal.
You aren't just memorizing drug classes.
No, you are expected to predict multi-organ failure.
Which is intense, but given how wildly toxic pentamidine is, it really forces the question, what kind of pathogen necessitates a drug this destructive?
Right.
If this is merely our second line defense, the organism we are targeting must be incredibly resilient. So let's establish the clinical landscape and the etiology of the invader itself, because we are dealing with an infectious, non-contagious anthropozoonosis.
Correct. And that term, anthropozoonosis, it indicates that the disease cycles between wild or domestic animal reservoirs and human populations.
Okay.
In the case of American tegumentary leishmaniasis, the primary etiological agents are protozoan parasites of the genus Leishmania. And while there are over a dozen species that can cause human disease in the Americas, the predominant and arguably most dangerous culprit in the Brazilian context of this exam is Leishmania brasiliensis.
Leishmania brasiliensis. And the epidemiology of this parasite is deeply tied to human expansion, isn't it? We aren't just talking about deep, uncharted Amazonian jungles anymore.
Not at all.
The detection rates are staggeringly high across the north and center-west regions of Brazil, specifically because of the intersection of deforestation, agricultural frontiers, and urbanization. It's an occupational hazard for loggers and farmers.
Absolutely.
But increasingly, it's affecting peri-urban populations, people whose neighborhoods are encroaching on the natural habitat of the vector.
The spatial distribution of the disease is basically a direct readout of environmental alteration. When human activity fragments a forest ecosystem, it disrupts the equilibrium between the wild mammalian reservoirs, so we're talking rodents, marsupials, sloths, and the insect vectors.
Humans just sort of stumble into the crossfire?
Basically, yeah. Humans essentially insert themselves into the zoonotic cycle, providing this massive new source of blood meals for the vectors right at the edge of the deforested zones.
Wow. And the identification of this specific Brazilian variant carries a really fascinating piece of medical history that mirrors our modern struggle with drug toxicity.
It really does.
Because while the disease broadly takes its name from William Leishman and Charles Donovan, who identified the Old World variants in India around, I think, 1903, the specific South American pathogen, Leishmania brasiliensis, was first isolated in 1911 by a brilliant Brazilian physician named Gaspar Viana.
Gaspar Viana is a monumental figure in tropical medicine. I mean, not only did he definitively identify the distinct morphology of the South American parasite, but within a year of his discovery, he also formulated the very first effective chemotherapeutic treatment for it.
Which is incredible turnaround time.
It was. He pioneered the use of a heavy metal compound called tartaremetic.
Tartaremetic. A trivalent antimonial compound. I mean, it sounds almost archaic, right? Like something out of medieval alchemy rather than modern pharmacology.
It was incredibly crude by today's standards for sure, but in 1912, it was revolutionary. So tartaremetic is potassium antimonial tartrate. Viana administered it intravenously. And the trivalent antimony is highly reactive.
Okay.
It rapidly binds to the sulfhydryl groups of essential enzymes within the parasite, halting its glycolysis and effectively poisoning it to death.
But the mechanism you just described, binding to sulfhydryl groups, that is not remotely selective.
No, not at all.
Because human enzymes rely on those exact same chemical groups, which explains the legendary toxicity of the treatment. I mean, the term emetic isn't a subtle warning, right? The drug-induced violent, intractable vomiting.
The gastrointestinal toxicity was profound. Because the heavy metal was so poorly tolerated, the therapeutic window was virtually non-existent. The drug caused severe sloughing of the intestinal intestinal epithelium, cardiotoxicity, hepatic damage.
Oh my God.
Patients were subjected to this grueling regimen where they were essentially poisoned to the brink of multi-organ failure just to try and outlast the parasite.
It's like chemotherapy in its rawest form.
Basically.
Yeah.
Vienna's discovery established the antimonial class of drugs as the gold standard, but it also initiated this century-long pharmacological tightrope walk that we're still engaged in today. We're still using derivatives of his discovery, constantly trying to mitigate the poison.
To understand why a century of modern medical science hasn't been able to design a safer, highly targeted therapy for this, we have to look really closely at the parasite's life cycle.
It's so complex.
Because it's not just floating freely in the blood where our immune system or our drugs can easily access it. We need to examine the cellular hijack and the anatomotopographic battlefield. And it all starts with a silent breach of the skin by the vector.
Right. The vector is a female phlebotomine sandfly, predominantly from the genus Litsonia in the Americas. When she takes a blood meal, she inoculates the infective stage of the parasite, which is known as the promastigote, directly into the human dermis.
Now, the promastigote is the highly motile extracellular form, right? It possesses this long anterior flagellum that allows it to navigate the viscous extracellular matrix of the host's skin.
Yes.
But it doesn't want to stay in the extracellular space. It actually actively seeks out the first responders of the human immune system, macrophages.
Exactly. The human immune system immediately detects the tissue trauma and the presence of foreign proteins. Neutrophils and macrophages swarm the site. Now, a macrophage's primary biological function is phagocytosis.
Which is basically swallowing things whole.
Right. It recognizes foreign invaders, engulfs them into a vesicle called a phagosome, and then fuses that vesicle with a lysosome.
This creates a phagolysosome.
Sounds like a terrible place to be.
It is an extremely hostile internal compartment. It's flooded with hydrolytic enzymes, reactive oxygen species, and highly acidic conditions designed to digest the pathogen down to its constituent amino acids. But the Leishmania promastigote isn't destroyed. This is where it gets really interesting, because the pathogen essentially uses the macrophage's own defense mechanism as a Trojan horse.
Yes.
It wants to be phagocytized. It allows itself to be swallowed, and then it initiates one of the most remarkable acts of biochemical subversion in all of microbiology.
It really is. Once trapped inside the harsh environment of the phagolysosome, the promastigote sheds its flagellum and transforms into a distinct morphological stage called the amastigote. The amastigote is non-nodal, and it's specialized entirely for intracellular survival. It rapidly alters the cellular homeostasis of its host. The surface of the parasite is coated in these complex glycoconjugates, most notably lipophosphoglycan, or LPG.
And this LPG coating acts as a molecular shield, doesn't
A
it?
shield and a saboteur.
Or saboteur.
Yeah. The LPG physically protects the parasite membrane from catalytic enzymes, but more importantly, it actively scavenges oxygen radicals, suppressing the macrophage's oxidative burst. Furthermore, the amastigote secretes factors that inhibit the vacuolar proton pumps of the macrophage, effectively neutralizing the acidic pH of the phagolysosome.
Wait, really? So it literally turns off the acid?
It does. It creates a comfortable, neutral microenvironment inside the very organelle designed to digest it.
That is wild. It's a complete architectural takeover. I mean, it's like a burglar who doesn't just break into a house with macrophage, but actually locks the doors, turns up the thermostat, raids the fridge, and just turns the house into their own personal fortress, resisting all the host acid attacks.
That's exactly what it does. The amastigote reprograms the macrophage's metabolism to supply it with lipids and nutrients, multiplies furiously through binary fission, and eventually ruptures the host cell, spilling hundreds of new amastigotes out to infect adjacent macrophages.
Which explains the immense pharmacological hurdle we talked about earlier.
This is exactly why simple antibiotics don't work. To kill the amastigote, a drug molecule circulating in the patient's bloodstream must first survive hepatic first-pass metabolism, diffuse into the interstitial fluid, cross the human macrophage's phospholipid bilayer, cross the membrane of the phagolysosome, and finally cross the parasite's own plasma membrane to reach its enzymatic targets.
That's like navigating an obstacle course inside a minefield.
You're asking a molecule to successfully breach 3 distinct, highly regulated biological barriers without destroying the host cell in the process.
And that cellular persistence leads directly to the macro-level anatomical destruction. Because if the patient's immune system, specifically the Th1 cell-mediated response, fails to contain the infection locally at the site of the bite, the parasite begins its topographic spread. And with Leishmania brasiliensis, we are looking at a very specific, devastating trajectory.
We are. Leishmania brasiliensis exhibits a highly specific tropism for the mucous membranes of the upper respiratory and aerodigestive tracts.
Okay.
While the primary cutaneous lesion might heal, sometimes even spontaneously, the amastigotes can disseminate silently via the lymphatic and hematogenous networks.
Just hitching a ride in the blood and lymph.
Exactly. And months or even years later, they emerge in the mucosa, most frequently targeting the nasal septum, the palate, or the pharynx.
The sources emphasize a specific vascular network in the nasal septum called Kieselbach's area. Why does the parasite preferentially anchor there? Like, what's so special about that spot?
Kieselbach's area, or Little's area, is this antero-inferior region of the nasal septum, where 5 distinct arteries anastomose. It is incredibly vascularized and slightly cooler than core body temperature, providing an optimal thermal and nutrient-rich environment for the parasite.
It's the perfect staging ground.
Exactly. When the amastigotes colonize this area, the host's delayed hypersensitivity immune response triggers a massive influx of inflammatory cells. And this creates a destructive granulomatous mass of tissue known as a pannus.
And this is where we see the severe structural deformities, because a crucial clinical distinction needs to be made here for differential diagnosis. Leishmaniasis destroys cartilage, but it heavily spares bone.
Right, that's key.
We really need to detail the mechanism of that specific destruction, because the inflammatory pannus doesn't secrete acids that dissolve the cartilage, right? It starves it.
Exactly. The nasal septum is composed of hyaline cartilage. Cartilage is entirely vascular. It lacks a direct blood supply and relies completely on the diffusion of oxygen and nutrients from its surrounding envelope of connective tissue, which is called the perichondrium.
Okay.
The inflammatory pannus, generated by the Leishmania infection, infiltrates and obliterates the perichondrium.
So you basically cut off the supply lines.
You induce total ischemia. Without the perichondrium, the chondrocytes, the cells that actually maintain the cartilage, they rapidly die. The cartilage undergoes a vascular necrosis and physically collapses.
Oh, wow.
And the septal perforation and subsequent collapse of the nasal bridge results in the classic severe facial deformity, historically documented as the taper face, due to the elongation and flattening of the nasal structure.
Taper face? That is devastating. And the fact that it spares the bone is a crucial diagnostic anchor, isn't it? If a clinician is examining a patient with severe palatal or nasal destruction and the underlying osseous structures, the actual hard bone, are necrotic and actively being destroyed, leishmaniasis drops way down the differential list.
Instantly.
You immediately have to pivot to considering pathologies like tertiary syphilis or certain invasive fungal infections, which, destroy bone and cartilage indiscriminately.
The morphometry of the destruction is also heavily influenced by the specific histology of the cutaneous inoculation site. Like, the depth of the dermal layer plays a significant role in the presentation of the primary ulcer.
How so?
Well, if the vector bites an area of thin skin, such as the face or the anterior tibia, the inflammatory infiltrate rapidly breaches the superficial layers, resulting in a highly expansive, exudative, and destructive ulcer.
But on thicker skin.
Conversely, bites on thick skin, like the dorsal torso, often present with more contained, indurated plaques due to the dense collagen matrix limiting the rapid spread of the inflammatory pannus.
Interesting. Now, if the human immune system is so easily bypassed and weaponized by this parasite, you really have to wonder if this is a unique biological vulnerability. But when you look at the broader evolutionary arms race, this kind of extreme biological subversion is happening everywhere.
Oh, absolutely everywhere.
So to truly grasp the sophistication of ATL, we need to look outside human biology and into the wild. Let's look at the evolutionary marvels connected to this disease, starting with an insect that literally eats houses, the termite. Specifically, Copta terms destroy.
The connection between a tissue-destroying tropical parasite and a wood-eating termite lies in the evolutionary biology of symbiotic protozoa. Earlier, we detailed how the Leishmania protozoan survives the incredibly harsh, highly acidic, and enzymatically lethal environment of the human macrophage's phagolicism.
Right, the acid shield.
It's an extraordinary feat of chemical resistance. Well, in the animal kingdom, the termite Coppetotrums destroy hosts its own community of flagellated protozoa, but in its hindgut.
Now, the termite's gut is basically a bioreactor filled with harsh digestive enzymes because the termite itself cannot break down the complex lignocellulose structures of wood, right?
Precisely. The termite relies entirely on those gut protozoa to produce the cellulase enzymes required to ferment the wood into usable short-chain fatty acids.
Okay.
The evolutionary parallel is profound here. Both the Leishmania parasite and the termite's hindgut protozoa belong to ancient lineages of single-celled eukaryotes that evolved distinct, highly effective biochemical shields to survive inside a host's hostile analytic internal cavities.
But their evolutionary endgames are diametrically opposed, aren't they? The termite and its protozoa are engaged in obligate mutualism. The protozoa develop their resistance to keep the host alive, allowing both to thrive. Leishmania, on the other hand, weaponized those exact same survival mechanisms purely for parasitic exploitation. It survives the lytic cavity only to consume the host cell from the inside out.
It's dark, but medical researchers actively study the robust biochemical pathways of termite protozoa to better understand the lipid membranes and proton pumps of Leishmania.
It is parallel evolution applied to completely different ecological strategies. And speaking of ecological strategies, when we examine the strategy of the vector itself, the sandfly, Luxomia longipalpus, we see a level of physiological engineering that just dwarfs modern pharmacology.
It really does.
We casually refer to it as a vector, but in reality, Luxomia longipalpus acts as a highly advanced biological stealth bomber.
I love that term, stealth bomber. Because if you think about a standard mosquito bite, an Aedes aegypti, for instance, the body immediately knows it's under attack. You feel a physical prick, mast cells in your skin immediately degranulate, releasing histamine, and you get immediate localized pruritus and a raised wheal.
You feel the itch right away. The immune system is sounding the alarm.
Right. But the sandfly bite is entirely different. It is clinically silent.
And the silence is chemically induced. The physical size of the sandfly is minuscule. It's about a third of the size of a standard mosquito, allowing it to land undetected. But the true weapon is its saliva.
Oh, the saliva is fascinating.
When the female sandfly lacerates the dermal capillaries to create a hemorrhagic pool for her blood meal, she injects a remarkably complex cocktail of salivary proteins, and the most potent of these is a peptide called maxidilin.
Maxidilin is an incredible molecule. It's one of the most potent vasodilators known to science. It forces the local capillary beds to dilate massively, ensuring a rapid, continuous flow of blood to the bite site.
Just turning on the faucet.
Basically. But it doesn't just manage blood flow. It actively hacks the local immune response.
Because maxidilin and other salivary proteins possess profound immunomodulatory properties, right? They actively inhibit the production of pro-inflammatory cytokines like TNF-alpha and interferon gamma. Furthermore, they inhibit the activation of the exact macrophages the Leishmania parasite needs to invade. By injecting the salivary cocktail, the sandfly artificially shifts the host's local immune environment from a hostile Th1 cellular response to a permissive anti-inflammatory Th2 response.
It's literally an immunological cloaking device. The vector chemically paralyzes the host's early warning systems, allowing the Leishmania promastogotes to casually slip into the dermis, locate a macrophage, and begin their transformation into a mastogotes before the host's immune system ever realizes the skin has been breached.
The efficiency of the salivary immunosuppression is so high that experimental vaccines are currently being developed not against the parasite itself, but against the sandfly's salivary proteins.
Which is a huge paradigm shift.
The theory is that if we can train the human immune system to immediately neutralize maxidilin, the localized inflammation will successfully trap and kill the parasite before it can establish an intracellular foothold.
That is an incredible therapeutic pivot. But until those vaccines exist, we are left dealing with the aftermath of the infection. And the endgame of Leishmaniasis, as we discussed with the cartilage necrosis, is characterized by horrific, disfiguring fibrosis and scarring.
Yeah, the aftermath is brutal.
The host's immune system eventually clears the parasite, but it replaces the functional tissue with dense, rigid scar tissue. Which brings us to the third animal comparison. The axolotl, Ambystoma mexicana.
The axolotl. It basically represents the holy grail of tissue repair. Perfect epimorphic regeneration. Unlike humans who heal deep tissue injuries through fibroplasia and scarring, the axolotl can regenerate amputated limbs, crush spinal cords, and massive dermal avulsions without forming a single strand of fibrotic scar tissue.
It's like science fiction.
The regenerated tissue is anatomically and functionally indistinguishable from the original.
And the connection to Leishmaniasis lies in the behavior of the macrophages at the site of the wound. We established that the facial destruction in ATL isn't caused by the parasite physically eating the tissue. It's caused by the human immune system's hyperinflammatory response, the granulomatous panis, destroying the perichondria.
Right, it's friendly fire.
Precisely. In human Leishmaniasis, the macrophages are locked in an aggressive M1 phenotype. They constantly secrete destructive metalloproteinases and reactive oxygen species, creating a cycle of chronic inflammation that obliterates the extracellular matrix.
Just non-stop destruction.
Right. But when the axolotl sustains an injury, its macrophages initially adopt that same M1 phenotype to clear debris. But crucially, within days, the axolotl's immune system perfectly orchestrates a transition of those macrophages to an M2 pro-resolving phenotype.
Wait, so they just turn off the destruction and immediately switch to reconstruction?
They do. They suppress the inflammation and secrete signals that direct local fibroblasts to rebuild the complex extracellular matrix exactly as it was, rather than haphazardly dumping collagen to form a scar.
Wow.
Medical science is intensely studying the axolotl's specific cytokine signaling pathways. If we can isolate how the Mexican salamander forces its macrophages to abandon chronic inflammation, the hope is to develop immunomodulators that can halt the destructive panis in mucosal leishmaniasis, forcing the nasal septum to heal regeneratively rather than collapsing into irreversible deformity.
It really highlights just how maladaptive the human immune response can be sometimes. We tear ourselves apart trying to kill an invader that has already neutralized our defenses.
Sadly, yes.
So bringing this vast biological complexity back down to the clinic, how does a dermatologist or an infectious disease specialist actually unmask this disease? I mean, the vector is invisible, the initial bite is painless, and the parasite hides inside our own cells.
The diagnostic approach demands extreme clinical vigilance because the incubation period can range from a few weeks to several months. The patient rarely associates the lesion with a specific insect bite.
They've completely forgotten about it.
Exactly. The clinician has to rely heavily on the morphological presentation of the primary cutaneous lesion.
And the classic presentation is highly specific, isn't it? It generally begins as a small erythematous papule that slowly enlarges, necrotizes in the center, and forms a painless ulcer.
Yes.
The borders are highly characteristic. They are indurated, elevated, and well circumscribed, often described as having a mold or frame-like appearance. The base of the ulcer is typically clean, displaying coarse red granulations. It does not produce purulent discharge unless there is a secondary bacterial superinfection.
And crucially, the clinician must physically palpate the regional lymphatic chains. Leishmania brasiliensis frequently induces a satellite lymphadenopathy.
Meaning a swollen lymph node nearby?
Yes. A firm, enlarged lymph node will often appear along the lymphatic drainage pathway of the ulcer, sometimes preceding the full ulceration of the primary lesion.
Okay.
Once the clinical suspicion is established based on the geography and the morphology, the diagnosis must be laboratory confirmed.
And the public health guidelines dictate a two-pronged diagnostic attack. The first is the direct parasitological exam. This is the search for the etiological agent itself. The doctor anesthetizes the area, uses a sterile scalpel blade, and performs a firm scraping of the inner border of the ulcer.
They target the inner border because that is the leading edge of the active cellular battle. The necrotic center is mostly dead tissue and debris.
Makes sense.
The scrapings are smeared onto a glass slide, fixed and stained, typically with a gym stain. Under light microscopy, the pathologist is looking for the distinct morphology of the amastogotes packed inside the cytoplasm of the host macrophages. They're looking for a round oval body containing a distinct nucleus and a rod-shaped kinetoplast.
It's the definitive proof. If you see it, it's there.
Exactly.
But the direct exam has severe limitations, particularly as the chronicity of the lesion advances. As the ulcer ages, the parasite load in the skin drops significantly as the immune system walls it off into granulomas.
That's the challenge.
So a negative direct scrape does not rule out the disease, which means the clinician must deploy the second tool, the Montenegro skin test, officially known as the Leishmanian skin test.
This raises an important question, right? Because the Montenegro test shifts the diagnostic focus from finding the parasite to finding the host's immunological memory of the parasite. It measures delayed type hypersensitivity, specifically a type 4 cell-mediated response.
Walk us through the specific mechanism of this this test. How exactly does it work?
Sure. The clinician intradermally injects a standardized suspension of killed Leishmania, promasticos the antigen usually into the volar surface of the patient's forearm. They then wait 48 to 72 hours.
Just dead parasite proteins.
Right. If the patient has been previously infected, their immune system will contain circulating memory, Th1 lymphocytes programmed to recognize Leishmania proteins. These memory cells encounter the injected dead antigens, become activated, and release cascades of cytokines, most notably interferon gamma.
And that cytokine cascade recruits a massive swarm of monocytes and macrophages to the injection site, creating a localized, hard, edematous nodule. If the induration measures 5 millimeters or greater, the test is positive. It confirms that the patient's cellular immunity has been primed by the parasite.
But this introduces a fascinating immunological quirk.
A dangerous diagnostic paradox, right? Especially when dealing with the severe mucosal forms of the disease. You're telling me a doctor looking at a slide of actively rotting mucosal tissue from a collapsing nasal septum will often see 0 parasites, but a skin prick on the arm will light up like a siren.
It is a striking clinical dichotomy, but it is pathophysiologically consistent. The mucosal destruction in Leishmania brasiliensis infection is primarily a hypermyalgic response, an extreme disproportionate hypersensitivity of the cellular immune system.
So the immune system is going crazy.
Exactly. By the time the septum is collapsing, the actual parasite burden in the tissue is extraordinarily low. The mastigotes are nearly impossible to find on a direct smear, but because the patient's Th1 response is in aggressive overdrive, their Montenegro skin test will be explosively positive, often resulting in massive indurations or even localized ulcerations at the test site.
The direct exam is blind, but the immunological memory is screaming.
That's a great way to put it.
But clinicians also have to navigate the exact opposite scenario, the Montenegro negative trap. There are specific physiological states where the patient is actively infected, carrying a massive parasite load, but the skin test remains completely flat.
The most critical scenario for false negative is profound immunosuppression, classically seen in patients co-infected with HIV. The Montenegro test relies entirely on a robust functional population of CD4 positive T cells to orchestrate the delayed hypersensitivity reaction. HIV aggressively targets, infects, and depletes those exact CD4 positive T cells.
So the patient enters an anergic state.
Precisely. Their immune system lacks the cellular infrastructure to mount a response to the injected dead antigen. Montenegro test reads as negative, providing a false sense of security, while in reality, the Leishmania mastigotes are proliferating unchecked by the compromised immune system.
Which is terrifying.
In these co-infected patients, the cutaneous lesions are often atypical, highly disseminated, and vastly more resistant to pharmacological intervention.
This perfectly illustrates why a laboratory result can never entirely replace expanded clinical judgment. A negative test in an HIV-positive patient with a suspicious ulcer requires immediate escalation to molecular diagnostics like PCR or histopathological biopsy.
Without a doubt.
The clinician must also rigorously rule out the differential diagnoses. A massive destructive facial ulcer could be paracoccidioidomycosis, a deep fungal infection endemic to the same geographic regions. It could be sporotrichosis. It could be a highly invasive squamous cell carcinoma.
A misdiagnosis here is catastrophic. If you mistake a fungal infection for Leishmaniasis and initiate the standard therapeutic protocol, you are subjecting a severely ill patient to weeks of systemic heavy metal toxicity without offering any antifungal benefit.
You're just poisoning them for no reason.
Right. The pathology will progress unhindered while the patient's renal and cardiac systems are battered by the misapplied therapy.
Which brings us to the final, most grueling phase of the clinical reality. Once the diagnosis is definitively confirmed, the therapeutic approach must begin. We established earlier that Gaspar Viana pioneered the use of tartar emetic in 1912. We are over a century removed from that discovery, yet the first-line defense recommended by the World Health Organization and the Brazilian Ministry of Health is still a heavy metal compound. We are still relying on antimonials.
Specifically, pentavalent antimonials. The most widely utilized formulation is mogulamine antimonio, commercially known as glucantime. While pentavalent antimony is significantly less toxic than the trivalent tartar emetic Viana used, it's still a remarkably harsh chemotherapeutic agent.
Glucantime acts as a prodrug, correct. The pentavalent antimony itself isn't highly active against the parasite.
Correct. The pentavalent antimony must be reduced into trivalent antimony inside the host macrophage or within the parasite's own phagolysosome. Once reduced, it exerts its lethal effect by inhibiting trypanothione reductase, the unique enzyme kinetoplastic parasites use to manage oxidative stress.
So it takes away their ability to handle stress.
Exactly. Without it, the parasite succumbs to the macrophage's reactive oxygen species.
But getting that heavy metal into the tissue is an intense logistical and physiological burden on the patient. Glucantime is administered via deep intramuscular injections or slow intravenous infusions every single day for a minimum of 20 consecutive days for cutaneous lesions and often extending to 30 days or more for mucosal involvement.
And the systemic toxicity during that month-long regimen requires intense clinical surveillance. Antimony compounds severely disrupt ventricular repolarization of the heart.
So you need heart monitors.
Clinicians must perform continuous electrocardiographic monitoring because the drug reliably prolongs the QT interval. If left unchecked, this prolongation can degenerate into torsade point, a potentially fatal polymorphic ventricular tachycardia.
Beyond the cardiotoxicity, it is highly nephrotoxic. The heavy metal is cleared by the kidneys, and the sustained exposure can trigger acute tubular necrosis. The clinician is actively monitoring creatinine and blood urea nitrogen levels to ensure the patient's kidneys aren't failing under the strain of the cure.
If the patient exhibits signs of severe cardiac or renal decompensation, the glucantime must be immediately suspended. This is when the clinician is forced to pivot to the second-line alternatives.
Right.
One option is liposomal amphotericin B, a highly effective polyene antifungal that also disrupts the Leishmania cell membrane by binding to ergosterol. The liposomal formulation reduces the drug's inherent nephrotoxicity, but it is astronomically expensive and requires dedicated infusion centers, making it inaccessible in many remote endemic rural areas.
Which brings the clinician right back to the other second-line alternative, pentamidine. And this brings us completely full circle to the trap in our few mark exam question. We spend the beginning of this deep dive tearing apart alternative C, exposing the catastrophic pancreatic necrosis that pentamidine inflicts on the islets of Langerhans.
Yep, the trap.
Let's briefly validate the remaining alternatives, the true statements, to solidify the pathophysiological mechanisms we've covered.
Let's do it. Alternative A stated, mucosal lesions are in most cases secondary to cutaneous lesions. Based on our anatomotopographic analysis, this is a clear verification. The promastigotes are inoculated into the skin, establish a primary ulcer, and then eventually disseminate hematogenously or lymphatically to the aerodigestive mucosa, establishing the destructive secondary lesions.
Spot on. Alternative B stated. Laboratory diagnosis is based mainly on parasitological exams and immunological exams, such as the Montenegro test. This aligns perfectly with the two-pronged approach we discussed. The direct microscopic visualization of the mastigotes, complemented by the assessment of the delayed hypersensitivity cellular response.
And alternative D stated, the drug of first choice for treatment is the pentavalent antimonial. This remains the clinical standard, validating meglumine antimoniate as the frontline, despite the intensive electrocardiographic monitoring it necessitates.
The underlying theme of this entire discussion is the desperate need for better pharmacology. We are throwing toxic heavy metals and pancreas-destroying diamidines at a parasite that has masterfully engineered its way inside our immune system.
They really are.
It highlights how deeply intertwined the history of parasitology is with the fundamental discoveries of human biology. In fact, our sources connect the ongoing fight against diseases like Leishmaniasis to 3 distinct Nobel Prizes in physiology or medicine.
It is impossible to discuss the pathogenesis of Leishmania without invoking the work of Elie Mechnikov, who was awarded the Nobel Prize in 1908. Mechnikov was observing the transparent larvae of starfish under a microscope when he introduced a thorn into their tissue.
Just poking them with a thorn.
Right. And he watched as mobile amoeba-like cells swarmed the foreign object and attempted to engulf it. He discovered phagocytosis.
He discovered the macrophage, and his discovery is the exact battleground for Leishmaniasis. The parasite's entire evolutionary strategy is predicated on subverting the very cellular mechanism Mechnikov identified. It intentionally gets swallowed by the phagocyte not to be digested, but to commandeer the cell as an intracellular fortress.
Sharing the Nobel Prize with Mechnikov in 1908 was Paul Ehrlich. Ehrlich is the father of targeted chemotherapy. He conceptualized the theory of the magic bullet, the idea that you could synthesize a chemical compound that would selectively bind to and destroy an invading microbe without inflicting any collateral damage on the human host's tissues.
Ehrlich proved his theory by developing Salvarsan, an arsenic-based compound compound targeting syphilis. And when you look at our current protocols for Leishmaniasis, it is glaringly obvious that we have not yet found Ehrlich's magic bullet for this parasite.
No, we definitely haven't.
Glupentime and pentamidine are crude biological shotguns. They hit the parasite, but the collateral damage to the heart, the kidneys, and the pancreas is massive. The magic bullet for Leishmania remains elusive.
But the pursuit of that bullet has shifted, which brings us to the 2015 Nobel Prize awarded to Satoshi Mura and William C. Campbell for their discovery of ivermectin. Now, ivermectin targets glutamate-gated chloride channels in parasitic worms. It is ineffective against a protozoan like Leishmania.
Right.
However, the significance lies in their methodology. They didn't synthesize ivermectin in a chemistry lab. They discovered it by isolating complex biological compounds secreted by streptomyces, bacteria found in soil samples.
They practice bioprospecting. They look to the chemical warfare already happening in the natural microbiome.
Yes, exactly. Their Nobel-winning success fundamentally validated the strategy of sourcing novel antiparasitic therapies from nature. Modern Leishmaniasis research is heavily invested in this paradigm, intensely screening alkaloids, flavonoids, and terpenoids extracted from endemic Amazonian flora, searching for a naturally derived compound that can breach the macrophage, penetrate the phagosome, and inhibit the amastigote without inducing the severe systemic toxicities of heavy metals.
So what does this all mean? Synthesizing everything we've unpacked today. We started by dismantling a deceptive medical board question, and in doing so, we mapped the entire landscape of American tegumentary Leishmaniasis.
It's a huge landscape.
It fundamentally is a disease of high-stakes biological subversion. You have a pathogen that utilizes a stealth vector to bypass acute inflammation, actively hacks the pH of the macrophage's lysosomes to survive, and triggers a hyperpenetrative immune response that ultimately melts the patient's facial cartilage while sparing the bone. And against this invader, the clinician is armed with incredibly harsh therapies, constantly balancing the eradication of the parasite against the induction of fatal cardiac arrhythmias or permanent iatrogenic diabetes.
For any medical professional listening, or anyone facing a rigorous exam in infectious diseases, you must anchor these systemic risks. The core mnemonic from our initial trap is crucial. The P in pentamidine stands for the P in pancreas. Pentamidine, pancreas. It induces profound beta cell necrosis. Never administer it to a diabetic patient without extreme specialized oversight.
That's a great tip.
Secondly, respect the Montenegro negative paradox. If your patient is immunocompromised, particularly CD4 depleted from HIV, a negative skin test is meaningless. Rely on direct molecular diagnostics. And finally, remember the structural boundaries of the destructive panis. Leishmaniasis obliterates the vascular cartilage, but it will generally halt at the bone.
But beyond the clinical guidelines and the heavy metal toxicity, there is one final, incredibly provocative area of modern research regarding this disease that we need to touch upon. It suggests that the outcome of this horrific infection might be dictated long before the clinician ever prescribes an antimonial.
Oh, this is fascinating. The frontier of this field is moving away from the internal immune response and focusing on the extreme surface. The cutaneous microbiome. Recent dermatological microbiology studies have demonstrated that the specific community of commensal bacteria living on the patient's skin at the exact anatomical site of the sandfly bite fundamentally alters the trajectory of the disease.
Wait, you mean the native bacteria like the staph and strep that just naturally live on our arms and legs are interfering with the parasite?
They are actively modulating the battlefield. When the sandfly inoculates the Leishmania promastigotes, the native skin bacteria are co-inoculated into the dermal puncture.
Okay.
Research indicates that the presence of specific strains, like certain populations of Staphylococcus aureus, immediately triggers complex signaling pathways in the local neutrophils and macrophages. This interaction dictates whether the host's initial immune response skews toward a highly effective parasite-clearing Th1 response, resulting in a minor self-healing lesion, or whether it spirals into the hyperinflammatory, tissue-destroying Th2 response that leads to massive mucosal destruction years later.
That is a staggering paradigm shift. The severity of a tissue-melting parasitic disease might be entirely dependent on the invisible microscopic garden of bacteria you happen to be carrying on your left ankle when you walk into the forest.
Exactly.
It completely redefines the concept of host susceptibility.
And it raises a fascinating therapeutic possibility. Instead of relying on a century of toxic heavy metals or pancreas-destroying diamidines to cure the disease after it has ravaged the tissue, could the future of prophylaxis be as simple as a highly targeted topical probiotic?
Wow.
Could we genetically engineer the skin microbiome of high-risk populations like agricultural workers in endemic zones to guarantee an immediate sterilizing immune response the moment the vector bites?
Now that is a profound thought to leave you with. We began this analysis by looking at the blunt force trauma of treating a tropical disease literally blowing up a patient's pancreas to kill a protozoan. But the ultimate solution might lie in the most delicate manipulation of our own microbial ecosystems. It proves that while the diagnostic and therapeutic waters of infectious disease are incredibly murky, if you look closely enough at the precise bioenergetics of a beta cell, the salivary peptides of a silent insect, or the regenerative macrophages of an axolotl, you can map the chaos. Thank you for joining us on this extensive deep dive into the pathophysiological mechanisms and extreme pharmacology of American tegumentary Leishmaniasis. Keep questioning the multiple choice options and never stop examining the brilliant, often terrifying biological mechanisms occurring right beneath the surface.